Hello, everybody. Thank you for joining. We are going to get started. Let's see. Can everybody see the slides okay full screen? So thank you for joining Pre-Health Shadowing. Today we have our guest speaker, Dr. Sam Shen, who will be joining us. Let me do a quick introduction to Pre-Health Shadowing. My name is Jason Bernstein. I'm a senior advisor to Pre-Health Shadowing. Pre-Health Shadowing is an international student-led, woman-led, minority-led, not-for-profit medical advancement purposes. We do have closed captions to accommodate students of all abilities and needs. If you have any ideas about how we can be more accessible, please let us know. If you want to stay in the loop, please join our mailing list. Sign up on our website or join our Instagram or TikTok to stay on top of all of our upcoming events. So we host students from all over the world. If you wouldn't mind taking a few seconds and typing into the chat where you're calling in from, and give us a sense of where everybody is today. I see Texas, California, New York, Texas, Wisconsin, Illinois, New York City, Delaware, Puerto Rico, Massachusetts. We have a lot of people coming in from Texas. We have Nina calling in from Aruba. Fantastic, everybody. Are you interested in being a part of pre-health shadowing? We are always accepting volunteers or senior team members. If you're interested, these are the links. You can also find these on our website. Some of the leadership roles that we have available right now are helping with grants and fundraising, video production, recruitment, diversity and inclusion, and editorial department head. If there's anything that you can do to help run PHS, please let us know. We're very interested in getting more volunteers. We also have a high school program. Our high school training program is offering leadership and healthcare education for pre-college learners. Fill out the application for our high school training program at prehealthshadowing.com/contact/join-our-team. And it does take money to run pre-health shadowing. We have a lot of expenses, including our hosting costs, our email costs, etc. If you or anybody you know can donate even just a few dollars, it'll help keep us going into the future. Thank you. If you have any questions while the doctor is presenting, please type them into the chat. We will get to those questions during the Q&A near the end of the session. Thank you. Try to take good notes. There will be an assessment at the end where we'll be pulling content from the presentation into the assessment. If you watch the presentation, you should have no problem passing the assessment. But please take notes so that you can refer to them while you're taking the assessment if necessary. We do offer certificates for everybody who passes the assessment, showing that you gave 2 hours of your time for shadowing activities. And if you don't mind turning your cameras on, it makes it a better experience for the presenter. He can actually see you. It's not always possible, but if you can, we'd love to see your faces. That said, let's get started. Dr. Shen, welcome.
Great, thank you. I'm going to post my slides here, and but thank you everyone for the opportunity to share on perspective of life as an emergency physician and a career in emergency medicine. I'm going to put my slides up. All right. Hopefully you can see that. Hold on. All right. All right. Well, thank you, everyone. I thought I'd just start with a quick introduction of myself. I'm currently a emergency medicine physician at Stanford Health Care. I also have a faculty appointment at the Stanford University School of Medicine. I'm a professor in emergency medicine, and I also have an administrative role as vice chair for clinical operations and quality. And so in my role, I see patients clinically in the emergency department, but I also manage the operations of the emergency department in terms of, how do we improve the flow? How do we improve the, how do we think about improving patient care in the emergency hospital setting in relation to the rest of the hospital? Other quick background, originally from Seattle, Washington. And then I came down to California, did my undergraduate at Stanford. I did medical school at UCLA, and then I did my emergency medicine residency in Boston, and then eventually made my way back to Bay Area, where I've been the last 10 years in my role. So first thing I wanted to also kind of highlight is that, there are different types of medical careers. And, as an emergency physician, just like with any other specialty, you can practice in different environments. And the environment I started with after I finished my training was in the community hospital setting. And then after about 8-9 years, I decided to make my way back to academic medicine. And so what is academic medicine? Academic medicine basically involves 3 missions. So when you work at a university-affiliated hospital, as a physician, you are responsible for 3 things. One is the clinical, and so you're involved in obviously taking care of patients, but the other is education, where you have a role in teaching students. We often are teaching residents in training, but also medical students who are not in residency yet, and also sometimes fellows. Fellows are those who have graduated from emergency medicine training. We also have another mission, which is research. And so the goal is to improve and advance the science of medicine. And then I would say there's a 4th bucket, which is administration. Administration is a part that I'm involved in, as I mentioned, kind of overseeing operations day to day, trying to, again, improve the systems of care. I want to also kind of mention other aspects of my background because I think it's pertinent when we discuss or when I want to share about, thinking about medicine as a career. Actually, before I started medical school and right after undergraduate, I spent a couple years in management consulting, and it was very different, obviously, from healthcare. But as a management consultant, and I was a junior associate at a firm, you're often looking at how to solve problems for large organizations. You're working with leadership of an organization to come up and help them develop strategies and execute those strategies. So I did that for 2 years before I went to medical school. And the reason I mention it is because I found that there are a lot of similarities, I think, in healthcare as with other industries. And I think the common theme is you often like to solve problems. And in healthcare, the problem just happens to be patient care. But this idea of liking to solve problems, I think, is a kind of common thread you'll see in many people who might be interested in healthcare. Actually, after doing the management consulting, I realized I really enjoyed kind of the mindset of thinking about a business, about an organization. And so I pursued an MBA actually between my 3rd and 4th year of medical school. And I was fortunate to be at an institution that was supportive of being able to do a dual degree while you're in medical school. Now it's a lot more common. When I did it, it was not that common as you can imagine, because you might seem like you weren't very serious about healthcare or medicine if you were trying to pursue something else. But nowadays, I would say it is very common to see these dual degree programs where from the beginning you can get a combined MD and MBA for those who might be interested in potentially pursuing something administrative or business oriented later on. And during business school, I spent a summer at an investment banking firm doing finance because I thought it was a very helpful perspective to not only just understand healthcare, but healthcare from the perspective of finance, because oftentimes when we think about how can physicians be more involved in terms of how care is delivered at a hospital, understanding the finance is also very important. And then my last experience I wanted to mention was after I finished my emergency medicine training, I actually joined a startup company that was developing a way to provide emergency medicine care to skilled nursing facilities. So patients who are in nursing homes often can find it challenging to get access to healthcare. And so I was involved in a startup company where we use telemedicine to bring the emergency medicine to the bedside of a patient at a nursing home. And by doing that, you improve the care because you can bring care almost instantaneously as needed. And again, I wanted to highlight these experiences because these are very relevant in terms of how I thought about emergency medicine, but I think how others, if you're thinking about medicine and specifically emergency medicine, I want to highlight that emergency medicine is it's a combination of a lot of different experiences within the healthcare field. And I've found that many of my colleagues who chose emergency medicine also are one that is very curious about other fields and have brought in a lot of different experiences. And so it doesn't have to be a very traditional track of being, let's say, a pre-med, a biology major, then you go to medical school, then you go to, then you do a residency, that there are, ways to go through your career and development where you can draw from different experiences, even different careers, different jobs that feed and actually help you become a better physician. So I wanted to kind of mention, like, what do people think of when they think about emergency medicine? And when I talk to my friends who are not in the healthcare field, naturally they start thinking about, well, what do they see in TV or in the movies? And it's interesting, and not that I've watched every one of these shows, but when I look at all the shows out there, and I would say, at least for my generation, the show ER was something that was right when, at the peak of it, was when I was in, kind of medical school. And then you see, again, a lot of other shows that are healthcare. And it's always natural to ask, like, which ones are accurate, which ones aren't accurate, and when you watch these shows, you can't help but then kind of be critical and say, oh, well, that doesn't happen in real life, or that's very overly dramatic. But I think when people think emergency medicine, they do think of they associate it with certain things, right? People are dying. You have a bad accident, or a lot of procedures, or a lot of blood, and to some extent that's very true. And I'll say, by the way, this is just my ranking in terms of what's realistic and what's not as realistic. So one of the things I just wanted to point out, and actually I actually give a talk to the undergraduate where I kind of point out these movies, and I kind of pulled scenes from movies that show how it influences what people think of emergency medicine. But one of the ones that I would say that's fairly common, right, is someone's unresponsive, right? And then somebody starts CPR and they're pushing on the chest. Well, that definitely makes sense, right? And that's what advanced life care support is all about. And then they bring out these paddles. They put a little gel and they start, they rub them against each other, and then they put it on the patient and they shock, and the patient's body kind of jumps up in the air. And then the patient gets resuscitated. And so there was actually somebody who studied this and said, in real life, what is the survival rate of CPR? Feel free to put it in the comments, but I'll just say that the survival rate is actually very, very low. But in the movies, if you were to, I think somebody actually looked at a whole bunch of different shows and calculated, it's like 17 to 18% survival rate, at least in the movies. But in real life, the survival rate is really, really low. It's like less than 5%, because it's pretty end stage once you hit that point. Or the other is this idea that, when someone's dead, they have this flat line, and they'll show this on the monitor, meaning the heart's not beating. And then they'll get the defibrillator to try to shock. But unfortunately, actually, when someone is in this type of rhythm, there is no value or indication to shock. But again, in the movies, it's definitely a very dramatic effect to do that. That's just one example, but it's actually a very fun talk to highlight many other examples in movies and TV shows that then portray emergency medicine. So what do we do in emergency medicine? And so I would say that, I want to kind of spend a little time just talking about, what are the common things that we see or what are the things that we think about? And so when somebody shows up in the emergency department, and majority of the hospitals will have an emergency department that's open 24 hours a day, 7 days a week, and they're staffed by emergency medicine trained physician. The things that we worry about when somebody walks through the door, because it could be anything, but we tend to focus on the emergencies. And so the ones that we, again, prioritize would be the heart attacks, the strokes, a child with asthma, somebody who's bleeding while they're pregnancy, or someone with abdominal pain. Again, this is just highlighting just a few things. And the reason is because, as you can imagine, all these things can lead to someone dying. And so therefore, we want to intervene in the most critical conditions. Of course, when we hear heart attack, the heart can stop, they can die. Stroke, they can be permanently paralyzed in a particular area of the body. If a child with severe asthma gets worse, they, of course, can stop breathing, and that's not good. Or pregnancy can be affected if they're bleeding. And certainly someone with abdominal pain, they can have an infection in any part of their organs that require surgery to remove or to fix or to start antibiotics to treat that. So I would say this is just a very brief snapshot of some of the things that we would consider very serious. Now, just because you show up to the emergency department does not mean that everything is serious. And when you look at most typical EDs, emergency departments, typically about 5 to 10% of people that show up are the most critically ill, meaning they will die if something doesn't happen in the next 10, 15 minutes. And then about 20 to 30% are those that we would consider low acuity. So minor things like you might sprain your ankle, you might have a cut on your finger. Again, these are things that are still important to the patient. They may not be considered life-threatening, but they still require attention that brought that patient to the emergency room. Everything else in between are things that are still potentially sick, right? So if someone comes in and they say they have a headache, that could be something life-threatening, like bleeding in the brain, or it could be something very minor, just like you had a migraine. And so that's part of the work, is try to differentiate what is truly emergent versus what is not. And so I like to kind of, delve further into, more specifically, type of things that you would do in emergency medicine. So as I mentioned, those are some of the cases. The other big type of case that you would see in emergency medicine is trauma. And so trauma, we classify into two types. There's blunt trauma, and blunt trauma typically tends to be more common. So those are the car accidents, people who fall, whether they fall from a ladder or from a ground. And then the other is penetrating trauma. So as its name implies, penetrating trauma is something where it penetrates your body. And so that could be a stabbing or a gunshot. And so depending on where you're located, there may be places that have a lot more penetrating trauma, some, or less. I've worked in a community hospital. We tended to have a lot more penetrating trauma. So, again, just more stabbings and shootings. And then currently at Stanford, I would say we tend to see a lot more blunt trauma, where it's the car accidents and things like that. Another big part of emergency medicine is procedures. And so oftentimes when someone's critically ill, or even they're not, there are certain procedures that need to be done to improve their health, or potentially even life-saving, or at the very least to absolve their of pain. And so one of the more common one is laceration. So you might cut your hand or some parts of your body, and so that needs to be closed, that needs to be sutured. Another is a shoulder dislocation. That's considered a orthopedic emergency, because if someone dislocates a joint, then you need to put it back as quickly as possible so there's not long-term complications and side effects. So in that particular case, you can see that the right shoulder of the patient certainly looks very different from the left shoulder. And that's because the head of the humerus bone has dislocated. It's out of the socket. Another procedure is a lumbar puncture. That's where you put a needle into the back to try to extract fluid from the spinal column. And we do that to look for signs of bleeding in the brain or infection around the brain. And it's actually fairly common to do it in kids because kids sometimes have a high risk of these infections. And then another common procedure is a chest tube. And so sometimes when a patient has, what's called a collapsed lung, or they have a trauma and there's blood in their lungs or blood around their heart, or blood that's causing issues with breathing or the blood pressure, you would make an incision between the ribs and insert a tube to drain fluid from the patient's chest. So these are some of the procedures that kind of within the scope of emergency medicine. I would say the most critical procedure that emergency medicine does is the airway. And so I would say this is kind of one of the more defining procedures for emergency medicine. So if you are in a situation where you're unable to breathe, so there's no oxygen going into your lungs, and there's no carbon dioxide coming out, you can only sustain that, for a few minutes before your body starts to shut down. And so a procedure that we do is called intubation. And what that is if you aren't able to breathe, you would put a plastic tube down into your mouth and into your lungs, into the airways of your lung, and then you would artificially pump air in and out. And when you do this, typically either the patient is not responsive or you give them medicine so that they're paralyzed and unresponsive. So you're completely controlling their airway. There are situations where you're not able to put that tube into the patient's lung. And if that happens, then you have to do a surgical airway where you make an incision in their throat and you put a tube through their what's called a cricoid membrane. And so sometimes you might see this in, again, in the movies, right, where they make an incision and try to put a straw through someone's neck. So these are kind of the maneuvers. But I would say this is probably the scariest maneuver or procedure, one of the scariest you would do in emergency medicine, because once you paralyze someone, once you sedate them, then effectively, the only way they can breathe or get any oxygen is through that tube. And so that's why you can imagine that if you aren't able to get that tube in, it can be very nerve-wracking because that's the only way that patient will get oxygen. And so that's a quick snapshot of some of the type of cases that you'll see in emergency medicine, as well as the type of procedures. Another big aspect of emergency medicine that I would say probably in the last 20 years or so is the use of ultrasound. And so ultrasound has really changed the practice of emergency medicine. I think more than any field, ultrasound is a significant part of the clinical practice. And what's nice about ultrasound is that, and specifically, I'm referring to bedside ultrasound. So this is a machine that you can see in the picture to the left that we can roll right up to the patient. And so it's portable. And while you're listening to the patient's heart or you're examining the patient, you can roll this machine right up to the patient and look at certain things on the patient by ultrasound. There's no radiation. Gives you information instantaneously, and you can act on it. And you're using the ultrasound usually for a few indications, specifically in trauma, in pain, patients with pain, trouble breathing, and dehydration. And what information you're trying to get is really a binary question. You're trying to answer, do I see blood in the body where there's not supposed to be blood? Or do I see air where there's not supposed to be air? Or do I see other things, yes or no? And so it's a really powerful tool now, because before ultrasound, you often would need to sometimes get a CT scan. Sometimes you might need to do other imaging. Sometimes you have to wait. Sometimes you have to observe for some period of time. And so if you look at the middle top picture, that's an ultrasound of someone's spleen area, which is in the left side of their belly, you see that circle? That circle is right over an area that's black. That black area represents fluid and likely blood. So within 30 seconds of putting a ultrasound probe on this belly, you right away have an answer to say, wait, there's blood there, and there's not supposed to be blood there. And so you can imagine how quickly that gives you information. If you look at the far right, upper right, that's a picture of someone's heart. And so if you're concerned that their heart's not beating well, again, within 30 seconds, you can see the 4 chambers of the heart. And then you can see if there's fluid around the heart that's blocking it. And then on the bottom middle, that's a picture of someone's belly where you can see their large blood vessel called the aorta. And sometimes people, when they come in and they are unconscious and their blood pressure is low and they're elderly, you might think, did they rupture their aorta? Well, instead of waiting for blood work and sending them to the CT scan, and you can just within 30 seconds take a look at the aorta and have an answer. And then now, even on the far right, on the bottom, we're using ultrasound to look for detached retina. So you can put a little patch on the eye, put the probe, and within seconds, you can see if someone might have a detached retina. So this is, again, a very powerful tool that emergency medicine has really, I think, advanced in the care of the patient. Some are even saying that the ultrasound is equivalent to the stethoscope, whereas a stethoscope has been around for decades, 100 years. This could now essentially be the replacement or a parallel tool to the stethoscope. All right, so in emergency medicine, what types of patients do you see? I think you can already appreciate that in emergency medicine, because anybody can walk through the doors of the emergency department, then in theory, you need to be prepared to see all types of patients. So somebody who is 1 day old to 100 years old, someone who's, again, male, female, pregnant. So you're seeing all types of patients. And so for many people, that can be very interesting, and that's what draws them to emergency medicine. For others, perhaps they only want to see kids, right? Or they only want to see, pregnant patients. So that's something to consider in emergency medicine. And so another way I like to think about emergency medicine is emergency medicine covers a wide breadth of conditions. Because again, when someone walks through that door, they could have anything. But the depth in terms of what you need to do and know for every single type of condition that exists is not as deep as, say, for example, if you were a retinal specialist. So I have a colleague who is a ophthalmologist. And in fact, within the ophthalmology, he specializes in just one part of the eye. So not just the eye in general, but we're now talking about just one layer of the eye. So you can just imagine how much that person knows when it comes to that one specific part of the eye, of the human body. And so in emergency medicine, even though we are not going to have the depth of knowledge as an ophthalmologist, but we still need to know the eye emergencies. We don't necessarily need to know everything about the eye and preventive care and long-term care, but we certainly need to be comfortable at least with the most emergent conditions of the eye. And that applies whether it's your heart, kidney, your skin, any other parts. So again, it's very broad, but the depth, it does not have to be as much as a specialist who's only focusing on that area. And I would say this is one of the reasons I think that drew me personally to emergency medicine, because growing up and thinking about a doctor, I just, without, this is obviously before I was in medical school, before I was even a pre-med, I just assumed all doctors were the same. You just say, oh, that person's a doctor. Hey, I've got this problem. What do I do? Right. And that's kind of this typical presentation. In fact, there's some, I go back to the TV and movies, like the Dr. House. I don't even know what kind of Dr. House is, because he seems to be every single specialty, depending on what the episode is. But growing up, I kind of had that impression that, oh, a doctor is supposed to know and be able to manage almost any question. And so emergency medicine was the closest to that because it's the type of field where I would say if you're stuck on a plane, someone's having a problem, if your family is calling to talk about their aunt who's having an issue, the emergency medicine physician typically is one I would say can address and help in those situations. All right, so now that you finish your emergency medicine residency, which is typically 3 to 4 years after medical school, then you can actually subspecialize within emergency medicine. And so these are 1 to 2 year fellowships, which come after you finish your emergency medicine training that allows you to pursue more specific training on an area of interest. And so the ones I highlight in black are the ones that I would say, kind of they've been around the longest. And so EMS is emergency medical services. So there are physicians that want to focus on working with paramedics, focus on how do you care for a patient before they get to the hospital. As I mentioned, ultrasound is a big field. And so there are a lot of ultrasound fellowship trained that can do even more advanced type of care using the ultrasound. Toxicology is your classic, the person, that handles all overdoses, all poisonings, and they often staff, poison centers. And so toxicology in general sits within emergency medicine, but again, there are people who want to continue to pursue and focus just on that. And then pediatric emergency medicine, there's some folks that even though your training covers kids, there are folks that want to continue to pursue further depth in just pediatrics. And then critical care. So again, even though emergency medicine, you're trained in critical care, there's a 1 to 2 year fellowship where afterwards you just want to work in the ICU in addition to working in the emergency department. And the ones I highlight in green are just some of the newer fellowships. So I run the administration fellowship at Stanford. So these are folks that want to potentially, maybe they want to be a hospital leader. Maybe they want to be a chair of a department. Maybe they want to be a chief medical officer. Who knows, right? But they spend an extra 2 years learning how to, how hospitals run, how emergency departments run. Innovation is a new one, especially being in California, in Silicon Valley. This is where we can look at, how do we work with startup companies? How do we look at developing digital health companies? We spend, our department looks at AI a lot. How do we incorporate AI into healthcare? And then space medicine. We have a few graduates from our program that now work at NASA. They are, flight physicians, for the supporting the astronauts. And again, you can see all the other fellowships that exist for those interested. I kind of mentioned this before in terms of, in emergency medicine, there are 2 tracks. And this is for every medicine. When you come out and you finish, you can decide, do I want to be in community hospitals or do I want to be in academics? And so I highlight this just because this is kind of the key decision point once you finish your training. If you work in the community, your sole mission is to do patient care. And if you go to academics, you have again that tripartite mission of education, research, and clinical. Having spent half and half in both, I would say it's not necessarily that one's better or one's worse. It's a matter of what do you like and what do you prefer and what brings you joy and what keeps you stimulated. And in general, some of the differences that people will use to evaluate is that the job market is often tighter in academics. There are just fewer positions in academic medicine in general. In community, it depends on where you live, right? If you live in a very popular city, let's say New York or San Francisco, or wherever, jobs might be tight because there are a lot of people applying there. But if you go to less occupied places, like if you go out into rural communities, it might not be very competitive because there just aren't as many positions and as much competition. Compensation typically is higher in the community, and this is that kind of the idea of private practice versus in academics. I mentioned that there are 3 missions in academics, and community is primarily clinical care. The lifestyle, it's hard to say. I think it varies, right? Because in community practice, Your sole mission is just take care of patients. You go home. There's no homework. You're not on call. In academics, you work less clinically, but you also have other responsibilities. And so it's kind of mixed depending on what you like. In terms of career flexibility and growth, I would say actually both have career flexibility and growth, just in different ways. In community setting, people might be interested in taking on leadership roles within their hospital. In academic setting, those opportunities still exist, but then you might have career growth in terms of research. You might have career growth in terms of education. Some people maybe they want to become a dean or associate dean or be part of the medical school and take on leadership roles there. And so again, depending on different tracks, you have different opportunities. And so when you think about emergency medicine, I would say these are some of the questions that I often will tell students, when they're thinking about what field. And so for emergency medicine, what kind of things do you like? Do you like to follow a patient over time? So in primary care, you might see the same patient for 30 years, or do you want to just see them for that particular episode? And are you okay with that? Do you prefer a faster pace versus a slower pace? Right? Emergency medicine tends to be very go, go, go. You're seeing one patient after another. You're often multitasking versus perhaps in a clinic, or even perhaps in an operating room that the pace is different. Do you enjoy more procedural type of work or versus more cognitive? In many fields, they're all cognitive, meaning they're all require you to problem solve and think. But things feels like surgery, emergency medicine, you tend to work with your hands more because they're just more procedures. And then lifestyle, what kind of lifestyle? Every field has a different type of lifestyle. Emergency medicine tends to be shifts, whereas other medical fields, you might be in the operating room for 10 hours a day, and then you go to the hospital. And then some fields, you're just in a clinic all day. So again, a lot of variations. A typical job for emergency medicine, a full-time is about 30 to 32 hours per week. And again, it varies. Again, there's a wide range, but I would say that, kind of the midpoint is about 30, 32 hours. It's very much shift-based. So you start a shift and you finish a shift, and that's it. The shifts can be anywhere from 8 hours all the way even up to 24 hours. I did a rotation at a hospital in Kauai, where it's a very, very small hospital, right, on an island. And so those shifts, you spend 24 hours in the hospital. But at some other places where it's very busy, so at Stanford, where we, see about 100,000 patients a year in our emergency department, all our shifts are 8 hours. Just because the feeling is that if you were doing, 10, 12 hours, you would just get really, really burnt out, over time. Emergency medicine is very much team-based. You're working with the nurses as a team, with the techs. If you have students or medical students or residents, you're all working as a team. And the classic job is you're working in an emergency department, though there are many other settings that I'll mention that you can work as emergency medicine. I talked about academic versus community, and I talked about opportunities to go through fellowship training. And so that is kind of like what the current typical classic emergency medicine job looks like. But as we think about the future, I would say emergency medicine is one of those that's constantly evolving. Because if you think about the skill of emergency medicine, you're there to see unexpected issues that are potentially life-threatening from all types of people, right? So to inherently be in a position to handle unexpected things allows you, I think, to be put into a lot of different environments. So what's happening now and into the future is that emergency medicine is now providing care at alternative care sites. So a lot of urgent cares, a lot of walk-in clinics, and I also call them CDUs, clinical decision units. These are patients that stay in the hospital for up to 24 to 48 hours. So you're now caring for these patients, much longer. And then many hospitals now are serving as critical access points because they might serve a community where they're the only hospital. And as such, they may not have a lot of physicians. So that emergency physician might be covering the emergency department. They may also respond to emergencies on the inpatient floor outside of the emergency departments. And so we're seeing a lot of evolution of the care of emergency medicine. Another big trend is the idea of telemedicine. And I mentioned how I spent some time in a telemedicine startup. But this idea that if a patient is having trouble accessing the hospital, well, why don't we bring the physician to the patient? And so you could have a physician sitting in an office using a camera and essentially a very glorified FaceTime, seeing a patient at the other end, and then providing care and consult. And maybe that patient on the other end, it might be at a nursing home where they have equipment. They might have an electronic stethoscope, a dermatology camera, a device looking at ears, the throat. And now as a physician, by sitting in my office, I can care for someone anywhere in theory in the world. And so this is something that is definitely happening. We actually have a telemedicine shift at Stanford to do exactly this. And so this is all moving towards this idea that, emergency physician is probably a very flexible, adaptable field. And I've heard this term, and I thought it described it pretty well. There are doctors who work in the hospital only. They're called hospitalists. There are doctors who only deliver babies in the hospital. They're called laborists. Well, it's almost like there's this emergency physician that's called an everything generalist or available list, because effectively, you're a 24/7 specialty that can be available anywhere. And so kind of some last closing thoughts. I would say in 2024, my perspective on medicine is I still feel it's a great field. Medicine kind of goes up and down. There's a lot of press in the paper, about the insurance companies and political aspects of the reimbursements and where's universal health care coverage, where's that going? And but in general, I would say it's still a great field. I would say that pre-med classes don't necessarily reflect what the job entails. Taking organic chemistry in college, I would say, that is very much not, that relevant in the end for being a doctor or a good doctor. It's a very long road, so you have to just prepare yourself for that long road. Lifestyle is an important consideration when you think about, what type of career you want. And then I would definitely just embrace different experiences because that not only lets you confirm whether you are making the right choice or not because you've tried other things, but it lets you minimize that idea that the grass is greener on the other side. When I finished college, most of my friends went into banking and consulting, or they went to startup companies, and they've done very well, right? And so I often hear other physicians saying, oh gosh, I wonder what it would have been like if I tried this or that or this, and medicine's all I know. And so I always say it's valuable to embrace other experiences and to consider and be open and even in the end, all those experiences will help you because a lot of what I do in emergency medicine, or just I think any physician field, I say I draw from my experiences from consulting, from my startup experience, or even from finance, at least in my role today. So with that, I will stop and happy to take any questions.
Thank you very much. That was very informative. Wonderful presentation. So we do have some questions that have been posted into the chat room. I'll read off a few of them to get started. I'll start at the end, actually. How do you see AI working into healthcare or emergency medicine?
I would say that
already?
Yeah, so it is happening and it's happening really, really fast. And so within my department, we've got about six physicians who are dedicated to AI research. And how are we seeing this? Well, we're seeing this in a couple ways. Certainly with ChatGPT, we actually have a Stanford GPT. We're seeing it in terms of helping with documentation. So I would say that's an easy thing to do, which is and not just transcribing, but having AI. So you could go into a room, see your entire patient, do all the just talk naturally, and then AI would basically put all of that into a form, and that's very into a concise, organized note for you that saves you a lot of time. And again, that's just one small example because in the past, you would have dictation, right, where literally just copies what you just said. Well, that's not that useful in a dynamic environment. So that's on one end. On the other end, we're looking at how AI can be predictive, right? So if someone comes in and they have this history, they have a medical record, can AI generate what the likely diagnosis is or what the likelihood of this patient is going to get sicker or not sick? So those are just some very quick applications. And then X-rays, we actually have X-rays that can be read by AI with very, very good accuracy, almost as good, if not better, than humans. And so we're seeing a lot of advancement, and it's only going to accelerate exponentially, not linearly. And especially in an area like Silicon Valley, where many of these companies are heavily invested in using this technology. So we have, and many hospitals we have teams of people who are just focused on studying AI and then applying it to the clinical setting.
Okay. Jenny has a question. Have you ever administered TPA to a patient or seen it be given? What did it look like? So can you
Uh,
start by explaining what
yeah.
TPA is and
Yeah, so TPA is is colloquially known as kind of a clot buster. So when someone has a stroke, it's because blood is not flowing to that part of the brain. And the reason blood isn't flowing to that part of the brain is because there's a blood clot that's blocking blood going to that part of the brain. So if there's not blood going to the part of the brain that moves your right arm and your right leg, then somebody won't be able to move their right arm, right leg. So TPA is a drug that breaks up the clot in real time. And so I would say, yes, I would say, having practiced for now, 15, 16 years or so, it's fairly common. I was, in our ED, in our emergency department, we probably give it maybe, 5, 6 times a month. If not more, probably more than that, depending, again, it just depends on the size, right? Because in a population of 100 people, you might say statistically, 3 people will have strokes, and then of those, how many people will then need that drug? And so what happens is, like, if someone comes in, they can't move their right arm, their right leg, you think they have a stroke, you need to give TPA within a very short window, and we try to give it, within 45 minutes. And so that's really quick, right? So you need to have a CT scan of your brain to first make sure that there's not a dangerous cause of giving someone TPA, because there might be other reasons that that person's not moving their right arm, right leg. But assuming you do all that workup, you show that there's not a reason not to give the TPA, you would typically give it. And then if it's successful, you'll start to see them, able to move their right arm and right leg. Or if they still have a little bit of weakness, then by giving that medication, the recovery is much better, so that they might have a residual weakness, but they can recover as much of their function as possible. And there are other medications, there are other interventions for stroke besides TPA. There's some that you can actually put in a little device. Think about it as a wire, almost like plumbing, right? It's like a roto-rooter. You put this into a pipe, you kind of break up the clot that's blocking the tubing, and then that opens up that blood flow.
okay. I've got a few questions about motivation to keep going through school and training despite the journey being such a long process.
Yeah, I mean, I think it just goes back to, like, what do you enjoy, right? And if you enjoy it, then in some ways, and I've talked about this with many of my physician colleagues, in terms of our experiences, going through medical school. In some ways, medical school is it's easy because it's a track. And so for people who would like to follow a track, it's easy because someone's just telling you what to do. Okay, after college, you go to med school. After med school, you apply for residency. After residency, you decide if you want to go to fellowship. The tests are all laid out for you. You got to take your step 1 test. You got to take your MCAT. So it's all like nicely organized. And once you're done with residency, then, typically you just get your job. I think in some ways it's scarier when I thought about potentially the business track, right? Because you come out like, oh, what do I do? What kind of job do I get? Do I go work for a startup company? Do I work for a big industry? Do I start off as a product manager? And do I have the experience? And it just, in some ways, that I find to be more chaotic. So it depends on what you enjoy. But if you do see yourself potentially enjoying medicine, then you're right. You do have to be prepared, and I think part of deciding if you want to pursue it is to talk to other people. You can never be 100% sure of anything, right? And there are many doctors who halfway through decide, oh, that's not for me, or they learn new stuff. But to the best that you can, you try to, that's why you try to talk to other people, try to, attend sessions like this, to try to see, is that something you see yourself doing? There are physicians who get their medical degree and then they stop. They don't pursue a residency. And if you do that, you just have a degree, which is still applicable, right? Because it still shows, hey, you're committed, you achieve something. And so oftentimes you're still very valuable to different organizations, right? Who just wants the fact that you persevere, you are a critical thinker. And there are people who then do residency and decide not to practice. At Stanford Med School, usually about 10 to 15 people graduate and decide not to do residency because they want to go join a startup, right? And so because in this area, there's a lot of opportunities and so that's okay, right? And people and we've had graduates from our emergency medicine training program, usually one every other year, that will finish their training and decide, I don't want to do medicine. I'm going to go work for a startup or another company. And so, but I think in the end, it's just, asking yourself kind of those self-reflections, right? And also just making sure, you have enough information or inputs to say, why am I choosing this path, or why wouldn't I choose some other path, if that's helpful.
Excellent. Um, one more question. Actually, two more. Um, so you said that a typical week for somebody in emergency medicine is about 30 to 32 hours. What does a typical schedule look like?
Yeah. So a typical, I would say, I'll start with the community hospital because that's the most typical, is, when you're part of a group of physicians working in the emergency department, you're all working, again, the 3 to 4 shifts a week, and you all share and rotate as equitably as possible the weekends, the nights, and the holidays. And so that is a downside, some people find with emergency medicine, right? Because you have to cover 24/7. So that means somebody has to work Christmas, someone has to work 4th of July or whatever holiday, someone has to work the overnight shift. And so, but because there's so many types of hospitals, emergency departments, the ones that are really, really small, it might be tougher, right? And so if you find yourself and there's some physicians that say that is not for me. I don't want to work in a small hospital with 3 other doctors because it's always one of us working. Some people might want to work in a hospital where there's, 50 physicians because then, there's just more balance. But at the end of the day, typically most groups try to share that. So you might be working every other weekend. You might share all the holidays. So you might work half the holidays or a third of the holidays and rotate that. And you might typically work, 3 to 4 overnight shifts. But there's some groups where they have folks that just only want to work overnight shifts. There's some people who are just like, I love working overnights. That's all I want to do. I want to get into that rhythm. They get paid more. They get paid a premium to work the overnights. And so the other people don't have to work overnights. And so, and again, the typical is usually 8-hour, 9-hour shifts. It's less common to have 12-hour plus shifts. And so you start your shift, you see your patients. At the end of your shift, you might stay an extra 30 minutes, 45 minutes to wrap up, but then you hand the care off to the next physician who's coming in to relieve you. And this happens 24 hours around the clock.
Thank you. And the final question, given how stressful being an emergency physician is, how do you take care of yourself after emotionally challenging cases?
Yeah, I would say that's very, very important. I mean, this idea of physician burnout, physician wellness. I should even add that we actually even have a fellowship now for physician wellness, where your whole focus for 2 years is to study physician wellness. I would say that hopefully there are system things that can happen. So your group, your employer, your hospital, the group that you work with, hopefully they're doing things to support wellness. Like for us, right? Like if you're sick, we have an on-call system. So if you don't feel well, you would tell your team to say, hey, I don't feel well. And there's a designated person assigned that day to jump in and work your shift. Versus if you didn't have that, doctors used to work when they had fevers and they're coughing and they just felt terrible, but they felt they had to just go into work. But now we want to be able to support that. We offer, for our residents in training, we offer Uber rides, right? They work a late shift, they work overnight. We pay for their Uber so they can go home and not have to drive. Covering the meals, making sure they have breaks during a shift. When you deal with a challenging case, I would say one of the most challenging case, right, is a death of a child, right? Then we have a timeout. So at the end of when you pronounce the patient, the whole team stops, takes 30 seconds to pause, to kind of honor the patient. But then you also take 5 minutes as a team to discuss the care, any opportunities, how do people feel about it? Do they need to debrief? Do they need a timeout? And so these are all things that have been happening over the last, I would say 5 years plus or so, whereas medicine used to be a lot more brutal, 20, 30, 40 years ago, or at least even when I hear about, the generation before me and they talked about what life was like for them, it's definitely a lot more brutal. Like I did residency at a time where you could be in the hospital for, 24, 36 hours at a time. And it just felt normal, right? Because if everybody's doing it, it just seems normal. But now, we're trying to put more restrictions on that. So again, there's a whole evolution to try to address, that you want somebody to be in this for a long haul and not burn out.
All right. Are there any other questions from people in the audience before we close out this presentation? Okay. Well, thank you very much, Dr. Shen, for speaking with us today. I'm going to pass the presentation over to Hamani to close out the webinar.
Hello, everyone. Thank you so much, Dr. Shen. Thank you. That was a really insightful presentation also for me. Yeah, so just for everyone in the Zoom right now, let's take a few minutes to kind of reflect on how the session went for everyone today. Let's take a few minutes and anyone can unmute or use the chat option to kind of reflect together. Let's try to answer these 3 questions, which are first, what brought you to the session today? What are some major take backs you got from this presentation? And what would you like to learn more about? Feel free to also use the chat option. All right. There's many other opportunities for you guys to also share your thoughts and your opinions. And you can do so by going to this article, Reflection Reviews, and you can submit your thoughts right here about this session today. And yeah, oh, perfect. Raina said it was interesting to learn about how the business track was incorporated into the medical field. Yes, that's definitely really interesting to talk about, especially thinking about minors in college as an undergrad for me too. Yeah. Um, yes. And everyone here that's watching, definitely, if you're interested, join as a volunteer or a team member, and you can apply that on the website. Yeah. And if you can, obviously donate. And we would love your help and appreciation. Yeah, help our program stay free and accessible to everyone. We run solely off of the time and donation of our volunteers. So yeah. And if you're here earning a digital certificate for today, or if you're interested in that, please do so. Just take our shadowing assessment, and on our website, and you can sign up for this free course, take this little exam, take the assessment, and it's only going to take you 10 minutes, pass with a 70% or higher, and you'll be able to get your certificate for attending today. I see all of the things in the chat, and thank you so much for your participation. Again, thank you so much, Dr. Shen, as well. And that's all we have for today. If you guys have any comments or questions, please, we would love to know more. And yeah.
Thank you very much. The
Thank you very much.
assessment is open, and everybody should be able to take it and get your certificate of completion.
Yes.
Thank you for your time.